Hi, everyone, and welcome. My name is Khurram Nasir. I'm one of the associate editor for Journal of American College of Cardiology. Today, I'm extremely pleased to be joined by Dr. Jian'an Wang, a senior author of a new phase 2 trial that just got published in JACC, focusing on SHR-1918, a fully human monoclonal antibody targeting Angiopoietin-3. This study explores whether the investigational therapy can further lower LDL and triglycerides in patients with suboptimally controlled hyperlipidemia, even when they are already on statins or other lowering therapy. Now, of course, we have grown interest in this target for tackling residual risk, especially for patients with mixed dyslipidemia. So, Dr. Wang, thank you for being here. And again, congratulations to you and your team on the impactful trial. Would love to hear more if you can give us some brief introduction about the study.
Thank you, Dr. Nasir, for having me. And thank you so much for giving me the opportunity to share my research. So the title of the research is Angiopoietin-like 3 antibody therapy in patients with suboptimally controlled hyperlipidemia, a phase 2 study. So as you know, Angiopoietin-like 3 inhibits the activity of lipoprotein lipase and endothelial lipase, increasing both serum LDL-C and triglyceride levels. SHR-1918 is a fully human monoclonal antibody against Angiopoietin-like 3. It is a multi-center randomized double-blind placebo-controlled dose escalation phase 2 study. So the aim of the study was to assess the lipid-lowering efficacy and the safety of SHR-1918 in moderate or higher risk of ASCVD patients with suboptimally controlled hyperlipidemia. So the eligible patients were at moderate or higher risk of ASCVD according to current guidelines for dyslipidemia, had now achieved the optimal LDL-C levels after 4 to 8 weeks of standard lipid-lowering therapy. Homozygous familial hypercholesterolemia and a serum triglyceride level over 5.6 millimole per liter were excluded. So this study was conducted at 35 medical centers in China, and a total of 333 patients were sequentially enrolled into one of 8 dose cohorts at a 4:1 active to placebo ratio. So patients received subcutaneous SHR-1918, 150, 300, or 600 milligrams every 4 weeks, or SHR-1918, 600 milligrams every 8 weeks. So alternating with the placebo for double-blind treatment of 16 weeks. The extension treatment so include SHR-1918 at a dose of 150, 300, 600 milligrams Q4W, Q4 weeks, over 36 weeks. So all SHR-1918, a dose of 600 milligrams Q8 weeks, over 40 weeks, and then followed by safety without the medication. So primary endpoint is a percentage change from baseline in LDL-C. Secondary endpoints include absolute change from baseline in LDL-C, triglyceride, and other lipid parameters, as well as the proportions of patients achieving LDL-C targets. Safety was also assessed with the laboratory test results and by the incidence and the severity of adverse events. SHR-1918 demonstrated a dose-response relationship with respect to percentage of LDL-C and triglyceride lowering compared to placebo, respectively. So it's worth noting that SHR-1918 administration every 4 weeks significantly reduced LDL-C for about almost 30%, and the triglyceride for more than 60%. So otherwise, SHR-1918 also substantially reduced non-HDL-C ApoA1, ApoB, with a better achievement of LDL-C targets and well tolerated. So our findings indicate that based on standard lower lipid-lowering therapy, Angiopoietin-like 3 inhibition with SHR-1918 further reduces in moderate or higher risk of ASCVD patients, which might be a potential therapeutic option for hyperlipidemia.
Thank you so much. Now, one thing that definitely caught my attention was the biology, and this has been gaining attention as a therapeutic target, but it has a different structure and half-life as compared to evenacumab. And there was also an interest that we see with the convenience of the dosing that you tested, both Q4 weekly and Q8 weekly regimen. Do you see the dosing flexibility as a key differentiator in the future lipid-lowering landscape?
This medication, SHR-1918, has a higher half-life. So it will be good for, the patient is complex. They can keep the medication easy, but has the same efficacy just as the other antibody, similar type of antibody. So I think the longer half-life will good for patient compliance to the medication.
Did you see any signals to antibodies or hypersensitivity that we should be aware of?
No, I don't think so.
Okay, that's good to know. And we did notice modest reduction in HDL-C and ApoA1, something that we have seen with other ANGPTL3 targeting agents. Is there something to monitor, or this is just an expected trade-off of the mechanism?
It's a mild HDL. I think we still need to monitor, but the lowering effect is very low. Hopefully, I think the most important to see maybe the phase 3, so we can, the most important to see the clinical events change in the later trial.
I agree.
Okay.
Yeah. Dr. Wang, one very nice thing about your study for this phase 2 was the long follow-up, almost up to 56 weeks, which gave us a very good sense of the safety and durability. Are you planning phase 3 or cardiovascular trial outcomes in the near term?
Yes, we are going to start. From the phase 2, we already achieved a good experience for this trial. So also the 35 centers, they joined us, a high-quality center in China for pharmaceutical trials. So we will start the phase 3 very soon.
That's fantastic. That's good news. Now, Dr. Wang, I'm a preventive cardiologist, and now we have several LDL-lowering agents like PCSK9 monoclonal antibodies, inclisiran, bempedoic acid, and also evenacumab, which can be used for homozygous familial hypercholesterolemia. Where do you see SHR-1918 fitting in clinically within this expanding toolbox?
SHR-1918 is good for control LDL-C with the triglyceride. This is a very good, I think. Some patients, when we use the statin plus some other type of medication for the triglyceride, it's not good. Sometimes combination may not go for liver or something. So I think that this is the SHR-1918. I think it's good for the SHR-1918. But the homozygous, in our study design, we excluded the homozygous patients. So we don't know, maybe we need to do further studies. Yeah, actually, in China, we have another group. They are just doing the study on the homozygous population, but the outcome has not come yet.
No, thank you so much. So the triglyceride reduction was very impressive. Do you think that that is something we should embrace? And which patient population do you think that the triglyceride lowering will be very important that we saw with this therapy?
I think most of the diabetic patients, diabetes mellitus patients, they have a higher triglyceride, but the LDL sometimes may not so high, but moderate maybe. So I think this medication will very good for diabetes patients.
Well, this is so wonderful, Dr. Wang, and thank you so much again for taking the time to walk us through the science, your expert opinion, the clinical insights, and what's coming next. I truly believe this is clearly emerging as an exciting target, and it is so good to see a very thoughtful and high quality trials like this one, which is going to shape the next chapter in lipid management. And we look forward to seeing where SHR-1918 goes from here. So if you have any final thoughts for the audience, please let us know.
I would like to say, SHR-1918 is a new type of the antibody. It's a Angiopoietin-like 3 medication. I think that it can lower both LDL-C and triglyceride. It will be very good for some kind of patients, especially like the diabetes patients. So also I hope, this trial is, the whole trial was done inside China. Hopefully, phase 3, hopefully outside China, more centers joined us, our study for the phase 3 studies. So make the trial more general availability for the whole world, I think.
We are all very excited and looking forward to the partnerships that will help grow this program globally. But again, thank you so much. Congratulations on the simultaneous publication at Journal of American College of Cardiology with your ACC late-breaking clinical trial. Thank you.
Thank you, Dr. Nasir, for interviewing with me. Thank you so much for your time.
My pleasure.